Would want to introduce our second speaker, and we have the Clinton Health Access Initiative, great Singh, coming in to give us the second presentation. And while she walks up here, okay, I want to also call on Dr. Maria Corcorran. Did I say that correctly? Mm-hmm. Please, are you in the room?
Yep. Okay.
Oh, together. Oh, you're welcome. So the tied speaker 2 and speaker 3 are actually here. I want to crave your indulgence to also quickly call up speaker 4, actually, so we can make good progress with time. Do we have here Damali Kabwadi in the house? Please come up so that you can really go from here when it's your turn to do so. So, ladies and gentlemen, I think we're ready to begin the next presentation. So please, over to you. Thank you.
Thank you. Thank you, Michael. Hi, everyone. I'm Grace Singh. I'm a senior manager at the Clinton Health Access Initiative, or CHI, and I focus on viral hepatitis and triple elimination, and I'm here with my colleague.
Hi, everyone. I'm Dr. Maria Corcorran. I am a clinical advisor at CHI and also based as an infectious disease doctor in Seattle at the University of Washington.
Okay, great. So we're going to be talking about opportunities to integrate hepatitis B within HIV and harm reduction services. So in terms of what we'll cover, so we'll first start off with just noting the global need, and then look at some global enablers. So we'll talk about guidance, products and tools available, some examples of implementation, and then we'll also touch on financing with a particular focus on Global Fund today, and then finish with a summary of practical takeaways.
Great. So as we've heard already during this conference, globally an estimated 38.8% of people who inject drugs have current hepatitis C infection. And estimates from the Global Burden of Disease study suggest that in 2021, there were over 231,000 deaths due to hepatitis C amongst people who inject drugs. Although the prevalence of chronic hepatitis B is lower amongst people who inject drugs, it is still estimated to be 8.4%, which far exceeds the prevalence in the general population, estimated to be somewhere between 3.2 and 4.1% globally. And in 2021, the Global Burden of Disease Project also estimated that there were over 13,000 deaths due to hepatitis B amongst people who inject drugs. So while the burden of hepatitis B is not as staggering amongst people who inject drugs, it shouldn't be left behind in harm reduction settings. And we have the tools to incorporate hepatitis B into harm reduction. As we just heard from Dr. Spearman, we have facilitating guidance that has really simplified and expanded access to hepatitis B treatment. We also have guidance that advocates for the integration of hepatitis B, hepatitis C, HIV, and STIs in a person-centered approach. We have effective rapid diagnostic tests for hepatitis B that are affordable and accurate, costing about $1 in high-burden countries. And as Dr. Spearman also pointed out, we have molecular diagnostic platforms that can be leveraged for a multi-disease diagnostic approach, being able to test for hepatitis B DNA alongside HCV and HIV. We also have cheaper treatment. The cost of TDF has been driven down over the past 2 decades thanks to its inclusion in HIV programming. And while the cost of TDF monotherapy for hepatitis B is not universally at parity with HIV program pricing procurement, it has fallen substantially. And then finally, we also have low-cost prevention in a very effective and affordable hepatitis B vaccine that costs anywhere between 25 cents to 75 cents per dose. And this could be further leveraged to vaccinate susceptible individuals within key populations. And I think when we're talking about hepatitis B, we don't have to create new vertical programs. We've learned a lot from chronic disease management in key populations with HIV, and hepatitis B can be integrated into existing programs without the need to stand up new vertical programs. I'd like to highlight some experience that CHI has in integrating HIV and HCV services for people who inject drugs and for people in prisons, and think of these as opportunities where hepatitis B integration could be leveraged. So, for example, in India, CHI has supported the Mukhyamantri Punjab Hepatitis C Relief Fund to provide free hepatitis C testing and treatment at both ART clinics and opioid treatment centers. Through these efforts, approximately 31,000 patients were screened and 2,800 were initiated on hepatitis C treatment. In India, CHI has worked with governments and non-governmental partners to launch hepatitis C screening and treatment programs across prisons in Jakarta, Bali, and West Java. And between 2019 and 2024, nearly 17,000 people in prisons were screened for hepatitis C, with 930 being diagnosed with chronic hepatitis C and 537 being initiated on treatment. And finally, in Myanmar, between 2017 and 2020, CHI Myanmar supported the National AIDS Program to expand access to HIV testing and treatment services for people who inject drugs and their families. And this led to screening of over 3,000 individuals, 35% of whom were found to be HIV positive, and nearly 2,000 people were started on treatment. And although hepatitis B integration has not been sort of widely publicized in the harm reduction setting, there are examples in the literature of how this has been done. And so in a 2019 survey of syringe service programs in the United States, about 46% reported that they were incorporating hepatitis B vaccination into their programs. This did decrease to 37% in 2021 owing to the COVID-19 pandemic. In a Swedish syringe service program between 1994 and 2013, they were able to vaccinate 75% of hepatitis B non-immune individuals, and 85% of those achieved a serologic response. Older data from the United States suggests that about 25% of syringe service programs are incorporating hepatitis B counseling and testing into their services, and published literature here from South Africa suggests that point-of-care hepatitis B testing alongside services for HIV and HCV is feasible amongst PWID. In this same publication from South Africa, they focused on the feasibility of a comprehensive and simplified decentralized model of care for HIV testing, HCV testing, and hepatitis B testing, with incorporation of treatment for those who were hepatitis B surface antigen positive, either with TDF-FTC, which would also provide HIV PrEP, or with TLD for folks who were co-infected with HIV. And then we have qualitative data from Uganda that suggests that integration of hepatitis B and HIV care services is feasible and acceptable to both patients and healthcare providers.
Okay, so now that we've covered some of the tools and implementation examples, I wanted to now look a bit at financing, and I think, we've obviously heard about the uncertainty around funding right now, and I think regardless of the current climate, we've always seen that harm reduction services in terms of resources have remained limited, and when they have been available have typically been a mix of domestic and donor funding, with the Global Fund being the largest donor contributor in low middle income countries. So I wanted to sort of focus on Global Fund and firstly just kind of recap the timeline of Global Fund investments. So it's Global Fund's HIV investment policy that has evolved over time to become more inclusive to hepatitis service integration. So in 2015, Global Fund introduced a conditional policy to address hepatitis C co-infection amongst people living with HIV. This policy was built upon in 2020 to then broaden to include integration of hepatitis care, that's B and C, for key populations, which includes people who inject drugs. And then for Grant Cycle 7, We saw the policy language was really clarified to confirm that countries could use Global Fund resources to provide hepatitis services to key populations regardless of HIV status, so for mono-infected hepatitis individuals. And harm reduction became a program essential, essentially demanding that countries would need to articulate plans in this space. So these policy shifts really evolved in response to growing evidence, growing enabling guidelines, and I think really strong country demand and multi-partner advocacy. So now coming to Grant Cycle 7, we're really excited to see the policy development from Global Fund, and I think we reflected that hepatitis stakeholders are not often at the table for HIV application development. And so to bridge this gap, CHI developed a toolkit summarizing the policy opportunities, some tools and guidance, and disseminated this to 21 countries. And we built upon that to provide a subset of countries some tailored support as well through the application process. In terms of what we saw, and I've really focused on the key population lens here in this results map, we saw that 18 of the 21 countries did include hepatitis components for their key populations, and 9 of these specifically articulated hepatitis B interventions for people who inject drugs. So this is an encouraging view of demand here, and I think overall, Global Fund announced that they'd approved $60 million US dollars for hepatitis commodities for Grant Cycle 7, and this was a 3-fold increase from previous grant cycle. Fast forward to this year, we've had the reprioritization process, and this has posed some risks. So Global Fund guidance recommended deprioritizing some hepatitis components, including active hepatitis B, screening and initiation for adults, though exceptions could be made for high prevalence settings or high risk groups. So again, we worked to sort of synthesize these policy changes and disseminate and provide some TA. The reprioritization process was really rapid, and I think we're still trying to quantify what impacts have taken place for hepatitis investments. And now we're looking forward to Grant Cycle 8, and so we're expecting guidance from Global Fund by end of this year and applications to open next year. And I think it will be really important for us to remain vigilant of what the policy says for people who inject drugs in key populations, and to clearly understand the opportunities and potential gaps around those policies for the next cycle. While the Global Fund replenishment is still pending, we can anticipate that countries could be receiving smaller allocations, and so tough decisions will need to be made. And so it will be important to be systematic as we can be, to identify what can fit within Global Fund budgets and where additional resources are going to be needed to support the services that are needed. You can find out more about more practical guidance in our advocacy brief that we just published with the World Hepatitis Alliance. And this outlines some opportunities and risks for hepatitis care for Global Fund programs as we prepare for Grant Cycle 8. So to wrap up, this just kind of summarizes some of the practical points that we've gone through. So I think from a testing and product standpoint, we've heard that hepatitis B screening can be integrated into existing service delivery and could utilize single disease or emerging multi-disease rapid diagnostic tests. And these could be offered at a single healthcare touchpoint. Viral load testing could be optimized through existing molecular diagnostic platforms. On the treatment side, there's potential to leverage price benchmarks that HIV programs have been able to access. And then we've also seen a number of examples of workflow and service integration. And I think these sort of demonstrate feasibility. And I will say, having walked around and seen some of the posters here as well, I think there are a number of other examples, and I look forward to the discussion that we'll have here. And then lastly, I think we obviously touched upon the policy scope with Global Fund, and I think the need for us to be coordinated as we go through to Grant Cycle 8. Okay, thank you.
Thank you.